Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for Culturally Respectful Care, engaging family systems and managing unique social drivers of health. The CMEO Snack Series is supported by an educational grant from CVS Health. A quick disclosure and fair balance note before we begin. We may reference data or clinical considerations that extend beyond FDA-approved labeling. When that happens, we'll clearly call it out and encourage you to consult the full prescribing information and clinical guidelines when making decisions for individual patients. So my name is Dr. Monica Peak, and I'm the Ellen H. Block Professor of Health Justice in the Department of Medicine at the University of Chicago. I'm joined today by my distinguished colleague, Dr. Arvind Garg. Dr. Garg, would you mind introducing yourself for the audience today?
Yeah, thank you, Dr. Peak. Hi, everyone. My name is Arvind Garg. I'm a tenured professor of pediatrics at UMass Chan Medical School. I am the founding director of the Child Health Equity Center there and vice chair of health equity for the Department of Pediatrics. I'm also an associate chief quality officer for health equity for UMass Memorial Health, the second largest health system in Massachusetts. I'm a practicing general pediatrician, been doing that for 20 years now, and I'm also a researcher in social determinants of health, trying to address social drivers of health within the context of medical healthcare delivery. So excited to be here today.
Hey, it sounds like you and I are the same person, except that you're in peds and I'm in medicine. It's really wonderful to have you here.
Thank you.
Um, so before we begin, I want to make sure that our audience knows that we're going to be trying to set just an informal tone for a discussion. And so in that vein, Arvin and I are going to be addressing each other by our first names. And so to frame our discussion today, I want to start by reviewing our learning objectives for the program today. And our first learning objective is to identify the principles of culturally respectful child and adolescent care. Our second learning objective is to develop care plans that reflect and respect individual family priorities, decision makers, and preferred communication strategies. Third, is to utilize a comprehensive social determinants of health screening and management approach, and to recognize the benefits of closed loop referrals, and we'll define what that means, to address identified family needs. And then last and fourth is to integrate system level coordinated workflows with schools and community resources, including considerations for rural and indigenous settings. And so let's start with the foundation, what we mean by culturally respectful care in pediatrics and why it matters. And so, Arvin, when you think about culturally respectful care, what are the core principles that you want clinicians to carry into everyday practice?
Yeah, it's a great question. At its core, culturally respective care centers humility, respect for lived experiences, and shared decision making, while still delivering evidence pediatric care. In pediatrics, when we take care of children, this means we don't just treat the child in front of us. We're partnering with their family, their larger ecosystem that takes care of them, and communication and trust are often the make or break factors. When we think about culturally respectful care, we want to treat children the way we want our child to be treated when we take them to see their doctor. If we want to treat our family members the way we want to treat family members the way we want to treat our family members, how we want to be respected. And I'd say I've learned a lot about this, not really in medical school when I was a student, but really from being at the bedside, being on the other side of the bed when I take my sick child to see their pediatrician, or I've taken my elderly parents, through the emergency room and to their doctor's visits. And I think when you're on the other side of the bed and you understand the pain, the anguish, the stress, the anxiety that our patients are going through, our caregivers are going through, then it really helps us, I think, become more humane in the care we deliver.
I think that's such a good point, is that thinking about what it's like on the other side of the white coat, because at some point in our lives, we are going to either be patients or someone who is supporting a patient in as a family member or a friend or our partner. And so what we want that care experience to be like. Was it a great care experience? Was it a terrible one? And so thinking about it's so eye-opening. Like, oh, the healthcare system is really hard to navigate.
It
You
is.
know?
It is. Even for doctors like us, right?
Yes, yes. And you spend all that time like waiting for doctors on rounds and oh, am I going to miss them? And and so really thinking it really just puts a fine point on who and how we should be when we're with patients.
Absolutely.
So, families come in many forms. And that's something that has become a topic of national conversation right now. Um, but there are multi-generational households, there's kinship care, there's foster families, there are blended families, chosen family supports. And those structures shape who is involved, and particularly with pediatrics, how decisions get made. And so, Arvin, can you talk a little bit about this and why it's so important in the setting of kids to sort of understand these different kinds of families?
Yeah, absolutely. Yeah, not every family is created equally as a family that we expect the structure to be. There are many family structures that are different than our own lived experiences, and we have to acknowledge that and be aware of that. So, a practical way to start is to ask early on when you meet that caregiver, who is in your family, is involved with your health decisions for your child. For example, as you mentioned before, in some households and cultures, an older child may function in a parental role by helping with siblings, appointments, or decisions. But it's important to navigate that with humility, not to pass judgment, but to understand where this family is coming from and why this child is in this role that they're in. Clarifying who holds decision-making power and authority to support the family structure. In many cultures, it's oftentimes not the parent, it's a grandparent or an elder, and we have to be mindful of that as well. And obviously, we want to avoid putting a child in an adult role during the medical encounter. And no matter what, we should always use qualified interpreters, not a child or a young adult as an interpreter. So again, just being humble to understand without expectations, without assumptions, who's not family, I think is a really important point to start with. Particularly as you said, Monica, families, there's so much variety in families, which is it's a beautiful thing that we have in this culture and in this country.
Mhm. And one of the things that I'll just add is that part of the reason that there are so many different structures of families, um, part of that has come about as a response to the marginalization process. And so if we think about African Americans in this family, in this country who, traditionally have been broken apart, um, for lots of different reasons. Um, Other family members have had to step in and care for people, either informally or adoptive or otherwise, either from, starting with slavery to the Great Migration to, institutionalizations, um, over involvement of the criminal justice system, just all these different structural ways that have disproportionately impacted communities of color, where family members have had to, um, be flexible in how they create caring for children. And so it is sort of a privilege to be able to have sort of the standard um, two-parent household that I think people who haven't been traumatized in the same way historically in this country take for granted. And so when people come with atypical families, know that may reflect a historical history of trauma in our country.
Yeah, absolutely. I couldn't have said that better, Monica. It's absolutely true. We have to understand where our families are coming from, not just in the present, but in their past and generationally as well. But also in the present, we have to understand that, many Patrick offices have banking hours, from 9 to 5 we're open. And it's difficult for many parents, many caregivers. They don't have the luxury or the privilege that I have to be able to take time off to take my child to see their doctor.
Yeah.
And so because of that, they have to have extended families and extended members who may have to fill in when they can't do it because they can't take time off from their jobs for a variety of reasons. And so we just have to be mindful of that as we move forward. And again, just coming with a sense of humility and curiosity and understanding and compassion, empathy is really at the end of the day, that's the most important thing. And we'll talk more about that, during the session, but that's really the most important thing that again, being on the other side of the bed, being on the other side of the white coat, at the end of the day, you want competent care, but you also want to have that empathetic care, which just is so powerful and so meaningful. And sometimes we forget about that as we go through medical school and training and residency. But at the end of the day, that's what it's all about. And if we want families to be true partners, we have to engage them both at the individual and at the system levels. And so again, the system level is so critical because we know when we meet that family, we meet that parent, we meet the caregivers, we meet that child, there's a larger ecosystem that they live in. There are structural factors, both in the present and the past, that have influenced and driven that social circumstances for why that child is the way they are and why that family structure is the way it is. And so when we talk to that parent, when we talk to that caregiver, it's really important to understand the family's priorities. That's one thing in pediatrics. We say in our Bright Futures Well Child Care Guidelines, the most important thing to do in that visit is to answer the parents, the caregiver's concerns. So, what concerns do you have today for your child, and for your child's health, your child's well-being, your child's development? It's really important to understand from them to bring their agenda to the visit as opposed to our agenda about asking about sleep and diet and other things which are really important, but may not be the top priority, the top concern that parents and families have. And that's really our job at the end of the day is to address their concerns. Thinking about system levels as well. It's really important for pediatric practices for caregivers to build structures that elevate the family voices, so we can provide more equitable, more compassionate, more empathetic, and more effective care as we move forward. So many clinics, many practices have family advisory councils, feedback loops, opportunities for families to provide real feedback about the clinical experience, and also get their views and opinions and thoughts about workflows that make it easier to communicate in the family's preferred languages, as well as just make sure that we're giving them respectful care throughout their whole process from check-in to checkout.
Perfect. And so all of the things that you're describing around engagement reflect sort of multiple opportunities um, in one encounter, but also the fact that it's an ongoing process through multiple encounters. And so it's not just what happens with the physician, but at the check-in desk, with the nurses, with, the entire team, that families understand that they're valued, and it's not just what people are saying, what they're not saying, the verbal and the nonverbal. And it's the entire health ecosystem that is letting people know that they're cared for, welcome, valued, and that the system will be a safe place for them.
Absolutely.
So, this slide brings up sort of the long game of trust, especially when guardians and adolescents have different priorities, confidentiality expectations, and prior experience of bias. And so, Arvin, what are a couple of the things that clinicians might do to help de-escalate power dynamics in the room?
It's a great question. And again, that's going to allow us to build these meaningful connections and relationships with our families that we take care of, and that's going to help us improve the care we can provide to our children that we take care of. So, one thing that comes off the bat is the thing about confidentiality. So, we're mandated caretakers and reporters, and so if there's something, a suspicion of child abuse or neglect, we have to mandate that. But I think sometimes families think there are things related to poverty, like social risks, social needs, that will put them at risk for losing their child or put them at risk for providers having more shame or losing respect for that family. And I think it's really important for us to kind of just centralize that to let families know that what they tell us is confidential. What they tell us is important for us to get a better understanding of their child's health and development. It's rare that unless there's something egregious that a parent is doing to hurting their child, which 99.9% of parents and caregivers, I would argue, are not trying to do that intentionally. We have to just understand that but caregivers and families may come from a different experience and different concerns and fears, both their own experiences, if they're minoritized or marginalized historically, as well as their parents and generationally. So I think just leveling the ground set, leveling the ground to make sure that families know that we are on their side. We are there to support their child in optimizing their health and development. We're their biggest cheerleaders is really, really important. And I think that's something at the end of the day, it doesn't matter what live experience we come from, what live experience our patients come from, but knowing that we're on their side, that we're going to do everything we can to help their child thrive is something that can make us more unified and can allow those barriers to come down and to engender trust. Um, and obviously with adolescents, we have to make sure that we tell parents that there is private time for us to speak to adolescents by themselves, for our young adults, and staying neutral and transparent with caregivers about what we can share with them, what we can't share with them. Um, and importantly, as well, accepting that resolution may not happen in one visit. So we may not get to that shared decision that we both all feel comfortable with. A parent may uh, decide to think longer about giving that vaccination, which happens a lot, unfortunately, right now. And we have to not make it black or white or contentious because I think that just dissolves relationship. But again, trying to use every lever necessary scientifically, culturally, based on their community, based on their child's health and development, avenues for us to kind of continue those hard conversations to get to the yes. It may not happen, but at least we can still respect one another and still help support that child in many other ways to help them achieve their optimal health and development.
Yes, all of those things are so important. Thank you for articulating them. Um, One of the things that you mentioned was that it's important to actually say out loud um, that I'm here to support you, and that to do the best I can for you and your family. We know that that is true, but often patients don't know that at all. And so I make it a point to always start that conversation, especially when people are hospitalized, when the stakes are high and they may not know who I am, to verbally express the things that we assume that patients know, but they may be feeling like that is not at all the case. And the other thing is in the current setting where we are starting to screen for social drivers of health, that brings right to the fore these issues that you were talking about around um, poverty and other things that historically have led to um, a lot of involvement of Child Protective Services. Now, and that has remained sort of part of the community conversation, just like, Tuskegee, long since practices have changed. And so for us to be able to, again, verbalize, we're asking these so that we can help, so that we can try to make sure that we decrease the burden that your family may be experiencing around food insecurity, so that we can refer you to appropriate resources. Our goal here is to make your family stronger and better, not to try and, you know, take, you know, take your kids away or to, bring in CP, like none of that. Our goal is to provide support. And so it helps us do better with screening for social needs, but also to try and underscore the trust that you were talking about. So thank you so much for talking about that. In my personal practice, I've seen that social drivers of health are a major contributor to the health outcomes because by the time they become adults is when we start seeing the diabetes, hypertension, all of the other things. But within pediatrics, there are additional layers around social drivers of health that kids may not have the control to navigate. And so, can you talk a little bit more about in the setting of pediatric populations, how we want to, and we've been talking about them, but can you talk more about why this is particularly important?
Yeah, it's a great question. And, we take a life course view of these social drivers of health. Um, it's been shown that 80% of health of children and adults across the life course is driven by these social drivers of health. And it's a cumulative experience. And so if you're exposed to these unmet basic needs, unmet social needs early in childhood, it has a cascading effect on one's child. It can on one child's health and development. It can disrupt neurocognitive pathways that affects brain pathways. It affects their physiological systems. It affects their learning opportunities. It affects the stress that they're feeling, both internally and externally. That affects how they see the view, how they see the world, and how they move forward in that world from conception and onward. And I think something that's different in pediatrics, it shouldn't be that different, but I think oftentimes for a child, we can't. It's harder to pass judgment for a child who's living in poverty, who's living without food or housing, because they're born in that circumstances. And whether we think it's random that a child's born that way or spiritual or some other entity, there is a certain advocacy, a certain sense of compassion that comes when you take care of a child who's in front of you, who we know is not it's not based on the choices that they've made. And again, for adults too, for many of them, it's not the choices that they've made. It's been this cascading confluence of factors since they were children that have put them in the situation to have unmet basic needs and social needs. And I think we just have to be inherently understanding of that, of our experiences that our patients have faced, particularly our Black and Brown patients, throughout the course of living in this country. And beyond income, beyond housing, food, and transportation, pediatric care is often shaped by other factors: language access, health literacy, caregiver stress, immigrant relation barriers, community safety, and social support networks. And the key is that these aren't side issues, that these are clinical issues. We know this is for a child's development. This is just as critical as, a healthy diet in many ways. And it's really important for us to understand that even if they don't have health conditions, but if they do, it's really important as we modify those care plans. If a child's diabetic, for example, and facing food insecurity, how do we manage that? How do we navigate that as we move forward? And that's where these factors come into play, um, not just the family's experience, but it cascades down to a child's experiences, both for their health, for their development, and again, how they see the world and how they interact with the world moving forward.
Yes. And I will say that it's been the pediatricians who have been talking about this for decades. All the other, medicine, everyone else has more recently come around to this idea.
Yeah.
It's the pediatricians who have always been the advocates, connecting these dots and, bringing it into the practice. And so, shout out to the pediatricians.
Shout out. Absolutely. I often say we're like a little kid brother or a little kid sister in medical specialties. Like we're really cute and stuff. But in this area, because we've
Yeah.
seen the effects on children and families, and we understand that perspective. Children are the poorest segment of the population for the past 50 years. It's impossible to be a pediatrician and not see this and view it. And so we're really excited to see this expanding across the medical system. We'll talk more about how to operationalize this and how to think about this and still deliver culturally effective and confident care moving forward. But these factors can also compound. So it's not just a child or families facing food insecurity. They oftentimes are facing multiple other unmet social needs: food, housing, transportation, for example. And all these can kind of confluence together. They can lead to missed visits, they delay diagnoses, worsening chronic conditions. That's why, silent fixes don't really work. There's a dam with multiple holes. You're sticking your finger in one of them, but there's still other holes that are coming in. And so we just have to think about how do we create a more comprehensive, unified approach that families really need to help them address not only one need, but multiple needs that's affecting their family and their children's health and development.
Yes. And so just like, you know, the social drivers don't occur in isolation, the social identities that tend to um, be associated with negative social drivers a lot of times, are intersecting. So if we think about race, ethnicity, um, a lot of times that might come along with immigration status and language barriers and poverty. Like there's a reason that some of these things are, correlated. And so um, we know that people with multiply marginalized social identities have sort of stacked impacts on their health outcomes. And some of that is because they have sort of, stacked negative social drivers of health for different reasons. And so you may be a person of color who's experiencing racism, but you also have come here from another country, and so are being chased around by ICE, or and so there are just multiple ways in which this can impact not just your access to goods and services, but your physiology. We know that chronic stress impacts your autonomic nervous system, your cortisol levels, and all of these things lead to downstream health effects around cardiovascular disease, cancer risk, et cetera. So these are things that are not just immediate, but put people at risk for long-term health outcomes as well.
Yeah, absolutely. And it starts from really from conception and moves forward. So it's absolutely true.
Yes. So how do we move from knowing to doing? And so I want to start talking about how to operationalize this. And so let's first talk about screening and referrals.
Sure. It's something I've been thinking about throughout my academic career, so it's something I can enjoy talking about because I think 20 years ago when I started working on this, I thought it was a much more simplistic view of how this actually can work. And it's been really challenging to see that it's not as easy as I thought it was 20 years ago. And so when we say screening, we mean using standardized questions, using validated tools to identify health-related social needs such as food insecurity or housing instability.
Mhm.
And oftentimes, what that means is we're using these questions to make a diagnosis for food insecurity, housing instability, or transportation needs. But it's not really a diagnosis. Where a family comes into the visit, and when they're getting screened, it's different than getting screened for medical condition like diabetes or hypertension, things that the family, the patient is not aware of that they have. When a family comes in, they know they have enough food for their family. They know whether they have stable housing. They know whether they have transportation. And so the screening in itself is important information for us as the medical provider, as the health care system to understand what that family has. It's not so important for a family because they understand that. They know what they have. And it's an opportunity for us to understand some of the needs that families have that are using validated measures, but it's an opportunity for us to ask more follow-up questions and activate a response pathway, one that engenders trust, engenders autonomy for our patients and families, and is also empathetic as well. So it's different than screening for a medical condition where we can easily, not easily, but offer a medication or offer a referral. This is more nuanced because, again, families know what social conditions they're facing, and families know whether or not they want to get assistance and help from their doctor or not, and whether it's helpful for them to share this because they know there's associated shame and stigma with this, particularly for communities that have faced structural inequities and have engendered these type of needs generationally. And so And there's been a lot of mistrust with the healthcare system because of the poor care, the really the apartheid care that we've delivered for many communities for generations here. And so we have to be mindful and we have to have understanding that families may not want to come to us, even though they have a need for food, because we haven't engendered that trust to help them both in their own experiences, but also in their extended family's experiences over generations.
Right. And so one of the things that I'm learning is that because right now I'm actually writing up a paper about sort of the experiences of people of color with the screening process, is that it's not just enough to ask the questions, that they have to be framed in a certain way. So here's the question, but people, it's like a living document. People may have questions about it. There may need to be some additional contextualization around the questions. Um, People may need to have a little intro to the screener as to why we're doing this, and so again, who's doing the screening, why, how, all of those are just as important as the fact that we're using validated questions. And then we also have to think about whether or not we're asking the questions in people's preferred language. Oftentimes, screening tools have been translated into Spanish, but not every language, and even if a tool has been translated, we still have to use those other processes to make sure that the uptake is ideal.
Yeah, absolutely. Um, the process is really important. It's a standardized process for us, but it's not standardized. It doesn't feel standardized to many patients who get screened. And the context may be understandable for one family, but for many other families, the context of why we're doing this doesn't make sense to them at all. And we have to just try to mitigate any of their fears, any of their concerns they have with screening as we go forward. And also the importance of a closed loop referral is really important, and what that means is that we're not just giving a phone number and just hoping for the best.
Good luck.
Yeah, exactly. Families are trying in of themselves are trying to navigate these systems already without our involvement. And so, we can document the referral, we can track the status, we can record the outcome, but that's really important to know, are we being successful in connecting families to these resources? So understanding outcomes like being connected or declined or being ineligible or being waitlisted, unable to be reached. And standardization. So in pediatrics and many health systems really are now doing universal screening. So we're not picking and choosing who to screen, and that's really important because it reduces bias implicitly and explicitly. It prevents us to subtly screen based on our assumptions about who we think has needs. And having a consistent workflow, having one that's standardized, reduces misneeds and inequities for all across races, across social class, across gender, across other dimensions of one's identity. So I've been really pleased that that's what health systems have adopted. But that being said, across that whole spectrum, people are coming with different understanding, different comfort level with being screened, and we have to be mindful of that as well.
Mm. One of the things that is a plus is that there are some software platforms that can interface with the EHR, so that if you're doing a referral from the electronic medical record and you're using certain kinds of platforms, then uh, the whoever you're referring to will let you know if the patient has arrived and has, made it for that service, so that you're not having to sort of track by hand and follow up to see what happened. That closed loop is sort of an electronic loop. And so using technology to facilitate the process is something that's on the horizon as well.
Yeah, I'm excited for the future to see how we can use technology to really track in real time how we're doing.
Yes. So I want to sort of zoom out for a minute and think about systems coordination, because families live in larger ecosystems, particularly around as we think about kids and their schools, their communities, and other kinds of support services in their neighborhoods. And so, Arvin, can you take us through this slide?
Yeah, absolutely. So, schools are major access points for children. I often tell um, people who want to listen to me that children spend much more time in schools than in the pediatric offices. And so we really need to partner with our schools who know them for multiple years to help with our children's health and development outcomes. And schools have support staff on hand that can help our patrons and our children, including nurses, counselors, behavioral health supports and specialists, nutrition programs, and coordination around IEPs, 504 plans for children with developmental issues or with learning disabilities. And then on the community side, we have to think broadly as well. We want to think about community health workers who are kind of embedded in our clinics and some of our clinics and some of our health systems, um, who can kind of be that linkage point between community resources and agencies and organizations and the medical system at large. But then also when we think about the community, we think about social supports, we think about food and housing supports, which unfortunately are continuing to get cut and slashed in this time period. Transportation, faith-based organizations, whatever's trusted and functioning locally. We have to think about when we think about food, for example, we can think about the WIC office that families go to if they're eligible for food services for themselves and children less than 5. SNAP benefits, food pantries that are community organizations, but also ones in the hospital or at churches or other organizations. And so it goes across the whole spectrum. And it's something we have to really consider when we, especially as think about social drivers of health. We know all those resources are outside the hospital, outside our clinics. And for us to be more effective in helping our families and helping our children and youth, we need to think about how do we create these stronger partnerships moving forward, and how do we embed and learn from the community and learn from the schools in a more integrated way to really help our children and youth flourish.
Yes. And so, if we are working for a health system that hasn't bought fancy software, that has all this information that connects to our EHR, how do clinicians go about finding resources to partner with?
Yeah. We really need to start with what already exists. We shouldn't recreate the wheel when it comes to resources, which I think is sometimes hard as physicians because we want to kind of like do it ourselves, but we're not the experts in this. And one of the first ones to think about this. Thankfully, public health has been a big component of improving health for children, families over the past 100 years and stuff. And so there are local government directories in your town or city. The 211 system, which many states have. If you Google 211, you can access some resources in your community. It can be filtered by your zip code. Advocacy groups, school district contacts, community coalitions, public health departments, so both locally and at the state level, and existing community networks. Building, maintaining our practice resource maps are really important. So referrals are timely, that they're meaningful, and we're not reinventing it at every visit. And so it may seem daunting, but there's many resources out there. There might be support staff who are aware of this, either social workers, but also medical staff, medical assistants, front desk staff who live in the community, oftentimes where physicians may not live in that community, and partnering with them, learning from their expertise, learning from many different voices can really help us understand what are the best resources to help our families with.
Great. I want to talk about two different communities that frequently don't get a lot of attention, and that's rural communities and indigenous communities. Their needs often overlap, but they're not the same. And so rural settings often face geographic isolation, access to specialty constraints, transportation barriers, and workforce shortages. Indigenous communities often have issues and barriers related to sort of legal issues around the indigenous communities and historical um, negotiations with the US government. And so telehealth is often the first solution that people think about, but there are some challenges around telehealth. And so what are some of the practical alternatives that you've seen that still support um, these communities and build continuity and trust?
This is really important for us to be thinking about. I'm not sure I have the silver bullet for this, but it's something for us to be paying attention to because if we don't, we can't build a better system for these oftentimes overlooked communities in our country. So again, telehealth can help, but it may not be feasible, right? Due to broadband gaps, device access, privacy constraints, or family preference. Conceptually, alternatives may include mobile services, school-based touch points. So again, schools are so critical for us to understand our children, how they're doing, phone-based supports, and trusted community partners. And Indigenous communities, they require additional principles that we have to really abide by and we have to be mindful of. Sovereignty, their formal engagement through travel protocols, historical trauma awareness, and again, being mindful about the trauma that has been intergenerational for that child when we see them affecting their epigenetics generationally. We had to think broader view of family and community, oftentimes for these marginalized populations because of the historic injustices that they faced. As he had talked about before, Monica, there have been different ways to that they view family in order for them for their children to thrive, as well as different cultural aspects of respect with elders and having elders make decision making for that child and for that community. And so again, coming in with humility, coming in with curiosity, coming in with respect. We may not know exactly how best to navigate this, but that's a great starting point for us to start from.
Yes, absolutely. And so one of the things we had talked about before is this sort of rub around child welfare and custody processes. And so when care coordination sort of intersects with that, teams should be aware of certain kinds of considerations from ICWA. And so there are some resources within the Bureau of Indian Affairs to sort of help navigate that. But I think the through line for this conversation, and also particularly related to rural communities and indigenous communities, is trust. Sort of building genuine partnerships, working through trusted members of the community, and doing things that are real and not just performative. That we have to be serious with our intentions, wanting the best for those communities and try and find true solutions to lift those communities up.
Yeah, absolutely, absolutely. It's the most important thing we can do as providers. Again, learning from the other, being on the other side of the bed, is earning trust for our patients and families. Um, doesn't mean that it doesn't mean that some families won't already have that inherent trust when they come to see us, but we still have to earn it every visit that we see our patients and families at.
Yes, absolutely. Um, but the other thing that I will say is that everyone wants to be healthy and everyone wants to have a clinician that they trust, right? And
Absolutely.
the fact that there's distrust or whatever, that's a barrier that no one wants to have, not the patients or the physicians. And so everyone wants that boulder moved out the way. And so they're just as happy, more than happy, because it's their family and their bodies, if that can be gone. But these are deep-seated um hurt and pain that have happened, because of real lived experiences. And so we have to sit with that and we have to make that right. But there's a real hunger for that healing process to happen.
Absolutely. And we have to be part of that healing process for our patients and families. And eh, it's we have to say that there's these huge power dynamics, right? That come in when we're taking care of a child, taking care of a family. And we have to be mindful of the power that we have, the power of our words, the power of how we treat families, the powers of how we and our implicit biases, how we innately connect easily with a certain family because there's a commonality that we share versus other families, and there might be an instantaneous commonality, but there is still a commonality in humanity, right? And who we are and what they value and what we value and what we prioritize in our life and what our families prioritize in their lives. There's this commonality that we just have to be able to engender. And I think just trying to find some link of commonality in that visit, the first couple minutes, showing that warmth, showing that compassion, showing that empathy, which again seem like very trite things that we're talking about. But at the end of the day, and again, this comes from my experience, again, taking a sick child or a sick caregiver, a sick parent, a sick sibling to the hospital. At the end of the day, that's what you really care about and what you really think about. And it's hard being a primary care pediatrician or being a primary care internist is very difficult, seeing 20, 30, 40 kids a day, being on in every moment in that time in that exam room, being present, being authentic, being empathetic, despite all the craziness that's happening, both in your own personal life, because we are human beings, and also in that day with multiple challenges you might be facing on a professional level as well. And so oftentimes we need to just take a check on ourselves and how we're behaving and how we're feeling to do it. It's an amazing opportunity. It's an amazing job. We're really privileged. It's a really difficult job as well. There's a high burnout rate for primary care physicians in general. But being mindful of that baggage that we're carrying as well is really important so we can meet families where they are and provide that compassionate care and understanding.
Absolutely. So, when you sense some mistrust or hesitation from an Indigenous patient or caregiver, what would you say is the single most important thing that you do or say in that moment to avoid escalating the sort of power dynamics and keeping that relationship intact?
I think the first thing is to like identify that mistrust, identify that feeling that just something's just a little bit off in that room right now.
Mhm.
And then instead of just kind of charging on and giving the recognition you want to give or making the next visit, the next plan, just sitting with that for a few seconds. And I think it depends on your relationship with that family. You either can call it out and be like, I feel like something just kind of like off here, and I want to be there for you. And again, I want to remind you, I'm your child's biggest cheerleader. I'm here to support your child to achieve whatever they want to achieve, and I want to support you to help them with that. So that's where I'm coming from. And I'm going to give you medical advice that I know is scientifically proven for today that is going to help your child. And that's where I'm coming from because I want the best for your child. And that we might be disagreeing about something, but I want to hear your perspective. I want to understand where you're coming from. And again, we may not agree today on that commonality, but we can respect one another. We can learn from one another. So the next visit, we can have a better understanding of our patients. I won't say priorities, but our patients' perspectives on the advice we're trying to provide. And so, this comes along with vaccinations in many communities, and it comes up with other medical decisions. And I think oftentimes when there is stress involved, when there's anxiety involved for a parent, either related to a child's health or development, is my child at risk for autism? The stakes get higher and the mistrust gets higher because the stakes are higher. You know, there's just more stress, and so we have to recognize that oftentimes stress drives conversations that we weren't expecting to have in that moment, and we and we have to just acknowledge that. And so again, just kind of sensing that, I think being aware of the sense of mistrust, and then kind of resetting the expectations and the values that you hold as a physician and where you're coming from, trying to do the very best you can to help that child, and that you're on you're on their side, you're not an adversary. I think that can help. Can't always solve it, because I think when it comes to your child's health and stress and anxiety, you can't always hit a home run, but at the very least, you can develop a stronger, mutually respectful relationship with that family.
Yes. I could not agree more. I think sometimes the tendency might be to just kind of keep it moving and be like, "Whew, that feels kind of awkward." But um, I always try and do the exact same thing, like slow it down and just acknowledge that the air has shifted, and try and talk about it, because that is, I won't say a teachable moment, but that's a learning moment for everyone to try to deal with something very difficult right then. Because if you don't, you're not going to get that opportunity again. Like, remember that last time that you were here? I sent some,
Yeah, it's not happening yet.
right. And so that also lets the family know that you're in tune with them all the time. And so it not only is responding to them in real time, but it's also sending a signal to them about how they see you in the future. And that as things come up, they'll remember that last time that you noticed, and they'll maybe more likely be proactive and just tell you, as opposed to just
Yeah.
feeling a certain kind of way. They'll know that you want to know how they're feeling. And so all
Yes.
of these things, I think, like you said, sort of build a relationship of trust and openness and a willingness to talk about things that may be difficult, but they're setting up skills for you and the family to be able to sort of take them on together in a trusting and respectful way. Yeah. So we've talked about lots of different kinds of populations and communities. And is there, I think for me, despite that, the through line is always like trying to find the humanity, building relationships, trying to get to trust. Are there any key differences that you see that would change your approach, that you would want to call out?
It's a really great question. It's there's probably more similarities than differences. I think at the end of the day, we want to make that connection with a family. We want to reassure them that we're on their side. We want to reassure them that we're trying to do the very best for their child's health, well-being, and development. We may disagree on some of the choices, but the advice we're giving is what we think scientifically, as of today, is the best advice we can give for that child to thrive. Knowing that sometimes things change. Like in pediatrics, we told families for a long time not to give tree nuts and peanuts to children before age 1, and now we realize the early exposure is better. So, things can change. And when they do change, we're going to try to do what's best. I think it's just important to recognize that there's many marginalized communities in this country, historically marginalized, indigenous, Black, Brown, and many other communities that have struggled and haven't heard their voices, and whose providers and whose healthcare team, physicians, don't look like them, and haven't had that lived experience. And I think it's just really important for us just to remember that. And I think, again, being on the other side of the bed with a sick child or with a sick parent, my parents immigrated from India. And so, culturally, there were just different aspects when they were sick that I was aware of, that was really important. They're very respectful and very, they're very respectful to providers and whatnot. But it doesn't allow us not to try to make that connection. And my parent may have my dad didn't had an accent, but he also had two PhDs. And so when you're when you're when you're in the visit, you don't really get that perspective, right? And oftentimes I didn't get that respect that I felt my father deserved when he was sick. And
Yeah.
so just trying to like be mindful of that, be mindful of everyone's lived experiences, and that no matter what circumstances someone is in, good, bad, ugly, it's everyone has the same dreams, the same desires for their health, for their well-being, for the life that they have, the life they want to have for their children and their grandchildren. And then, so I think again, there's more commonality than not. And I think the shift from like culturally confident care, we probably remember that from like 20, 30 years ago, where we're saying this group is like this, we had to have to provide this type of care for this group and this type of care for that. Like that just reinforces stereotypes and reinforces stigma, and not two individuals from the same community are the same individuals regardless. And so again, going back to this commonality that we all have, for us as physicians to bring humility, which again, I learned a lot in medical school back in my day. Humility was not one of them, but understanding the importance of it is really, really critical. And I'm grateful that medical education has been changing and has been incorporating this much more now than back when, I was going to medical school. So again, I think commonality, bringing your best self, seeing the best in everyone uh, in that exam room, no matter what's happening in the world, what's happening in your personal life, what's happening in your patient's personal life. If we can just remember that, I think we can move to better outcomes for our children and families that they will respect and that they will connect with, and will help us develop even more powerful and meaningful relationships.
Well said. Thank you. So that brings us to the end of our session, and just what a wonderful way to sort of wrap it up. I'm going to try and um, give us some SMARTY goals. We used to say SMART goals, but we've added an IE around inclusivity and equity. And so SMARTY goals are ones that are specific, measurable, attainable, relevant, timely or time bound, inclusive, and equitable. And so basically trying to take what we've talked about today, and have some goals that like I can do it and like very tangible. So as an example, within 1 week, ask 5 or more families who should be a part of making health decisions. And then document the family structure and decision makers, including who should be involved in person versus phone or video in the electronic medical record. Or within 1 month, complete health-related social needs or social determinants of health screening in 10 or more pediatric well visits using a validated tool. And then for each positive screen, um, do a referral that is a closed loop referral, including key caregiver preferences like do they need a language, need extra language services or interpreter, who is their decision maker contact, and then sort of assess the outcome status within 2 weeks. Another might be within 6 weeks, in 10 or more adolescent visits. Implement and document a confidentiality and private time workflow plan. So, meaning explaining confidentiality and limits, offer time alone, etc. And then I have two more. Within 3 months, establish one school and one community care coordination pathway. So, for example, a school nurse or counselor, 2-on-1 food assistance, food and housing assistance resources, and then complete 5 or more referrals through this pathway and track the referral closure. And then, like an ongoing thing, is to center cultural humility before diagnosing behavior, screen for ACEs, so adverse childhood events, and social determinants of health. And then one of the things that we frequently talk about here is ask what's happening before you ask what's wrong. So, what's going on in the child's life, before sort of asking why are they behaving in the way that they are, and then partner with families as experts in that child's life. And so, anything you want to add to those SMARTY goals?
Those sound fantastic to me. No, nothing else to add, but really important to have goals to try to achieve and try to aim for. So those were great.
Right. So for those who like to go deeper, CME Outfitters has additional clinical information and certified educational activities available on their website. You'll also find the Health Access and Social Responsibility Hub, which offers free resources and education focused on equity, access, and culturally responsive care. The CMEO Health Access and Social Responsibility Hub also has more resources to help increase your skills in fostering a welcoming, fair, and inclusive environment. And so, as a reminder, the program is part one in our series. Part two addresses EPSDT for children, screening, prevention, and care coordination in Medicaid and beyond. Other snacks in the series will cover trauma-informed care for youth and team member and stakeholder roles for integrated support of children and families. We hope you'll explore those as well, as they are built on and reinforce today's content. We would like to thank CME Outfitters for their partnership in creating this education, and we are very grateful, always grateful, to CVS Health for their independent medical education grant that makes this series possible. To receive credit for today's activity, please complete the post-test and evaluation. We appreciate your feedback and want to hear from you. Tell us what you like, how we can improve, and what additional topics you'd like to see us address. And so, thank you so much for your sharing your expertise today. It was such a pleasure sort of seeing my soulmate in pediatrics and learning from you. Just really thank you so much.
Yeah, no, thank you, Monica. This was a lovely conversation and love to speak with you, and I'd love to have met my soulmate as well. Thank you.
All right. And thank you to our audience. We look forward to seeing you and just imagining how you might translate this into your own practice. Thank you very much for